Afternoon, testing.
It doesn't.
Yeah.
Okay.
Hello, everyone. Just testing. Hope everyone is okay.
Okay. So, all right. So, okay, that was a quick test. Thank you, everyone. Thanks to all the attendees. As they're
So thank you very much. Dear colleagues and friends, it's great to see the range of participants from different countries and regions, and as well as partners. I'm Dr. Teresa Kasaeva, Director of the WHO Global Tuberculosis Program, and I'm very pleased to welcome you today to this important event, WHO Global TB Symposium. You may remember that this event was very popular, happened in the past, and now we decided to revamp it, to bring it back according to the numerous requests, and traditionally organizing it in advance of the UN World Conference on Lung Health. So we are pleased to restart this tradition. So we are organizing this symposium to mark also the launch of the 2021 Global TB Report. So the symposium will also showcase the work undertaken by the Global Tuberculosis Program and World Health Organization in general across all three levels. I mean, with the focus on TB response, and especially in the context of the COVID-19 pandemic. As we all know, TB remains one of the top infectious killers in the world. And this year's Global Tuberculosis Report highlight the extent to which COVID-19 pandemic has reversed years of progress in providing essential TB services and reducing TB disease burden. It also presented the status of progress towards targets at the first ever UN General Assembly high-level meeting on TB in 2018 and its political declaration. So we are also looking forward to the next high-level meeting, which will happen in 2023. And this report gives us excellent opportunity to look at our challenges, advantages, and urgently move forward and to address these critical gaps and provide further progress. Following the launch of the report last week, we've received excellent coverage with more than 1,090 articles in media and with the reach in millions in social media. This is exactly the attention we need, and I know that all the partners are working hard promoting our latest information. We indeed need all hands on TB because the messages are very concerning and urgent actions are needed. We have a very distinguished lineup of speakers and panelists from countries and partners, including civil society. This event is being live streamed not only on Zoom, but also on YouTube and on our interactive virtual platform, NTB Forum. We have a very busy agenda today, and we look forward to having an interactive session. Today, we would like you to post on Slido as we proceed quick solutions that you see as a priority to rapidly ramp up the TB response and reach targets. Please post your questions on the Q&A function. So let's dive into the first session, which places the spotlight on WHO's Global Tuberculosis Report. This session will consist of an overview from WHO on the main messages emerging from the report and a look for the new digital report with our TB monitoring and evaluation team. We then welcome our close partners' perspective from USAID and Global Fund, and then hear from 5 countries transitioning into and out of the 30 high TB burden list. We will have some time, I hope, for a rapid Q&A on the report. So for this, we invite you to use the Q&A function on Zoom again. So I would like to start now with my presentation by sharing data and key messages emerging from 2021 Global TB Report. So this year Global TB Report highlights that TB, as I told, remains one of the biggest infections disease killer just after COVID-19, causing 1.5 million deaths, including more than 214,000 of people with HIV. TB is the leading killer of people with HIV and the major cause of death related to antimicrobial resistance. We can see for the first time over the decade increase in TB death, returning us back to the level of 2015. We see 5.6% increase, and it's very, very concerning, and more concerning because these trends are continuing. So you can see on this slide the trends and the current situation. In 2020, fewer people accessed life-saving TB care. 9.9 million people fell ill with TB, and only 5.8 million people reported to have access to care, down from 7.1 million in 2019. You can see that the pool of so-called missing people is growing. 4.1 million people were undiagnosed, didn't receive timely treatment, timely access to the treatment, and or not reported. If you will look at the trends in the notification, this figure speaks itself. Dramatic drops, and all our previous efforts, you can see we've managed to escalate significantly to minimize these gaps and the number of people who are not able to reach the services. But this pandemic reversed all our efforts. And you can see that 16 countries accounted for almost 93% of global drop in notifications, and especially the contribution to these numbers made CRO and WIPRO region accounted for 84% of global reduction. India 41% of drop, Indonesia 14%, Philippines 12%, China 8%. So now if we will look at the situation with drug-resistant TB, we see that the situation remains critical. There is ongoing crisis, and only 150,000 people were started on treatment for drug-resistant TB, down from 177,000 in 2019, 15% drop. And it means that only 1 in 3 of those in need receive access to the life-saving treatment. Our NTB strategy targets were not reached globally, though we have some positive trends and examples in the country we had before COVID-19. Now, of course, picture is different, but if we will look again at the global numbers, only 11% reduction in TB incidence, 9.2% reduction in TB death, and almost half of all people with TB and their families facing catastrophic costs. Globally, 8 countries that rank from 1st to 8th position in terms of number of cases accounted to the 2/3 of the global cases in 2020. So here you can see trends in is estimated TB incidence by regions. We can see the impact in slowing down progress, and only 1.9% decline for the incidence and 0.87% reduction for the absolute numbers. It's less than in previous years, and unfortunately, based on our modeling, we are forecasting for the and predicting growth in TB incidence beginning from 2021 and further. Again, I would like to repeat and highlight: if urgent measures will not be undertaken, TB is so-called slow epidemics, and the impact it's obvious cannot be immediate, but the estimates will grow, and this growth will start already in 2021. Next, please. So, high TB burden countries and countries from the global watch list, still few of them managed to achieve the NTB strategy 2020 milestones of 20% of reduction in TB incident. And you see this progress up to 2020, but further, again, the situation is changing and changing rapidly, not in the positive way. Trends in the estimated TB death, as I told, in the regions are the repeating those at the global level with some differences. Of course, it's not completely the same situation, and we can see that the growth is different, and it depends on the recovery of the services, how fast regions and countries are provided continuation of essential TB services. So these trends up to 2020 now are changing their trajectory. Again, we had some positive examples of countries reaching 2020 milestones in the death reduction, and we hope that these countries will manage to sustain their situation despite of COVID-19, and we would like to encourage them to do this. Situation with catastrophic cost is also very concerning. We can see that especially for those with drug-resistant TB, the TB itself and TB treatment is heavy burden. 87% are facing catastrophic costs, and all people with TB, at least, as I told, in 50% of all the cases are facing catastrophic cost. With social economic crisis, this situation again we are predicted that will become worse. And now let's look at our high-level meeting political declaration targets and progress to date. 40 million targets provided by treatment by 2022. We are halfway, it's 50%, and with very limited time ahead. Remind you that these are targets by 2022. And due to the current disruption, double and triple efforts will be needed to stay on track. TB treatment of different categories are also on different stages of progress. The most concerning is situation with coverage of children with drug-resistant TB, and with the in general, not only children, but the whole category. I would like to remind that WHO updated all the core guidelines. We have much better opportunities, and patient-centered, home-based fully oral treatment should be provided as soon as possible, and of course with the support of the digital technologies for the adherence. Progress toward 30 million targets is even more problematic. Only less than 30% progress, and again, situation is diverse in different subgroups. We can see that coverage with people of people living with HIV, it's very advanced, and we can see that the targets are already overachieved. Remind you, 6 million targets, 7.2 million people have been already provided. In comparison, household contacts aged below and above 5 years, especially those above 5 years, only 1.6% of coverage. The guidelines are again available for all the groups, but the funding is a huge problem. And in this COVID situation, it could become really life-saving. We can prevent of development of active TB disease. So research and innovation, as well as overall funding, are chronically underfunded. And in the current situation, we can see again drops in TB funding. We had even before COVID-19 50%, less than 50% available, and even out of this 50% now we have less. And again, when the issue of funding could be easily addressed if there is a prioritization, understanding, and the same level of response as to COVID-19. So very, very important information and analysis is related to the social determinants monitoring. And you can see the contribution of different risk factors and the growing role of such determinants as undernutrition, diabetes, HIV, alcohol use, smoking, and of course TB is disease poverty. Rates of poverty are growing, and these determinants should be addressed in the same time with TB as a disease and as a medical problem. So impact of COVID-19 on TB response, as I told, we can see first of all in the increase of TB death, in the dropping notification and access to the essential health services, including a drop in the access to TB preventive treatment, 21% drop in compare with the last year, and these are all very concerning trends. So I will not stop on the modeling, but our modeling clearly shows that impact of COVID pandemic on TB mortality up to 2025 will continue. And unfortunately, we're expecting further growth. But of course, we don't want to expect, and the situation will fully depend on the speed of the recovery of the essential services. Faster we will manage, less additional deaths we will have. Impact on the TB incidence, as I told, is also there, but the curves are a little bit different, because as I told, impact on the incidence is a little bit delayed, but it is there, it will be there, and it will be seen. You can see on the examples of the modeling on few high TB burden countries. So we will be happy to work close with you and to provide further guidance and information how to mitigate these risks. As you know, we are continuing monitoring COVID impact on TB notification on monthly and quarterly base, and we can see that the reductions are continuing in 2021. Unfortunately, drops in TB notifications are still significant. The largest relative reduction on notification compared with 2019 we can see For example, in Gabon, 80%, Philippines, 37%, Lesotho, 35%, Indonesia, 31%, India, 25%. So, but we see some exceptions like Tanzania, Zambia, and these examples should be further and will be further examined. We should understand better the reasons, and if these are best practices which we are collating already, they will be disseminated broadly. So again, colleagues, COVID-19 pandemic has reversed years of global progress in tackling tuberculosis, and for the first time, TB deaths have increased. This needs urgent actions, urgent investments in TB, and this we address not only to the country officials, but also to the international donors and funders. So you can find more details on our website, and colleagues will explain what will be new, and in our report also you can find app versions and download it for free in 3 languages. So this is in brief, and I would like to stop here in the interest of time to give more space for you for your questions and answers, and would like immediately now invite Dr. Catherine Floyd, Unit Head of the WHO Global Tuberculosis Program Monitoring and Evaluation Team, with colleagues Hazim and Irwin, to provide an overview of the new digital version of the report.
So thank you very much, Teresa. And with Irwin's help, I will show you some new aspects of the global report this year. So this year we decided to make it a more web-centric report. So if we just scroll down, this is the landing page that is being shown. And it explains here that the 2021 edition is in a new and more web-centric format, with basic idea that the content is being made available in more bite-sized chunks that we hope are easier to read, digest, navigate, and use. So essentially this year we have the report in 2 major components. If we scroll down a bit, you can see on the left, there is what looks like a traditional global TB report, but this is a shorter and slimmer version compared with previous years. It basically has about 30 pages of the main findings and messages, and then there are also 6 annexes in this main single PDF document. But then on the right, you have what is new. So what we're calling here the full digital report, where there is expanded and more detailed content available on web pages. So you can see there the main topics that are covered, and they are the same as the main topics that are covered in the single PDF of the report. We have a section on the COVID-19 pandemic and TB. There is content on TB disease burden. There is a section on TB diagnosis and treatment, on TB prevention, on TB financing, on universal healthcare and TB determinants, TB research and innovation. Now, these are the major sections with expanded and detailed content, and some of them are more substantive than others. So, for example, TB disease burden is broken down into 3 different subsections, where there is a web page on TB incidence, there is a web page on TB mortality, and there is also a page on national TB prevalence surveys. And similarly, the content on TB diagnosis and treatment is broken down into 4 different components, one with the basic notification data, another on diagnostic testing, another on TB treatment, and another on drug-resistant TB treatment. And the other one that is broken down more is the one on universal health coverage and TB determinants, where there are sections on universal health coverage, on national TB patient cost surveys, and then on TB determinants. And each of these web pages is providing content in a standardized format. So basically what you have on each of the pages, and there are 14 in total, is you have some text commentary, about 1,000, 1,500 words of text commentary, followed by a series of figures mostly, and in some cases also tables. And there's generally about 10 figures following the text content. So the idea here is to make the quantity of content on each web page manageable in terms of reading it and digesting it. And then the other thing, if we go back to the landing page, there's also a section you'll see there on featured topics. Now, these are things that we previously used to feature really in boxes within the main content of the report, but this time that content is on web pages, and this year we have 6 that are featured. So there is a featured topic on case-based TB surveillance. There's one on country success stories in innovative programmatic TB responses to the COVID pandemic. There is a case study of TB and COVID in India, looking at the impact and the response. There is a featured topic on the multi-sectoral accountability framework TB, looking at progress in its adaptation and implementation at country, regional, and global level. There's then one on TB and diabetes, and lastly, one on WHO TB guidelines, really profiling updates in WHO TB guidelines that have been published between November last year and October this year. And then if we go back to the landing page again, you can see there's also links to technical annexes. So this is mainly an annex explaining the methods that are used to produce the estimates of TB disease burden. And then there are links to country, regional, and global profiles. You can see also below the heading of data, there is a link where anybody can download all of the data that have been published alongside this year's Global TB report. And the last thing I just wanted to highlight, Teresa already mentioned it in her presentation, but there is, as usual, the Global TB report mobile app. I say as usual, actually, we've only been doing it since 2019. So this is the 3rd edition of the mobile app, but this is really a very good resource to look at if you're looking for country-specific detail, because lots of the key data and indicators are there within the app. And I will stop there, but that's just to give you a brief overview of the New Look report this year. And there is what you will find in the app that is also being shown. So I really encourage everyone who's interested in the report to look actually at all of the different components of it. The single PDF where you find a summary of the main findings and messages, but also all of the expanded web-based content, especially for topics in which you have a particular interest, and then to download the app where you can really find a lot of data for individual countries, as well as the WHO regions and the global profile. Thank you very much.
So thank you very much, Catherine, for your comprehensive overview, our new web-centric format of the Global TB report. So I would like now invite a representative of the USAID, the largest bilateral funder of TB efforts worldwide and the main supporter of the Global Tuberculosis report as well. And Sevim Ahmedov is lead of the team on prevention and M&E of the United States Agency for International Development. Sevim, please, floor is yours.
Thank you very much, Dr. Kasaeva. And first of all, let me start with congratulating WHO and you specifically, Dr. Kasaeva, for your leadership in developing this this report. It is a tradition every year in around this time for us to take a stock of the status of the tuberculosis epidemic across the globe. And as you and presented in as you presented in your slides, this year the status of that epidemic is really sobering, and unfortunately we are breaking with the tradition that over the years we showed steady progress towards reducing incidence and mortality across the globe. And this year the story is very quite different. It is a sobering sobering situation for all of us that we have been monitoring over the year. But this year's report clearly summarizes the devastating impact that COVID has had on the TB programs. So in terms of also, let me congratulate and emphasize that it was also very critical as COVID was the impact of COVID was being felt across the globe. WHO also took a very critical step in providing more frequent data for the first time on a monthly and quarterly basis to allow the global TB community to track the impact of COVID on the TB programs. And I hope that we will continue to have more frequent reporting of the data, and for us to be able to have more real-time data on the for TB notifications, and also from some regions we also had more frequent reporting on the drug-resistant TB notifications. And I also hope that the number of countries that will have capacities and will report more frequently on a monthly or quarterly basis will continue to increase in the years to come. So what, as I said, COVID has clearly demonstrated that while the global TB report continues to provide critical service in monitoring the epidemiological trends and burden of TB across the globe, a significant gap still remains in getting more timely programmatic level data that are needed to design appropriate responses to rapidly changing situations in the countries. Last year and this year it was COVID, but I'm sure that there will be other emerging airborne pandemics in the future which will have similar, if not worse, impact on TB at the global level, but also those impacts will allow us, and the more timely data always allows us to make the critical decisions that are needed for programmatic purposes, but also to shift resources where the needs are needed, where the needs are the greatest. We as a global community will continue to need to place a relentless and invigorated focus to support countries in strengthening their routine TB surveillance systems, which will improve the quality of the data for both the global TB report and provide for more specific epidemiological estimates of the TB burden, but also provide more timely programmatic data at the country and global levels for improved decision making. To paraphrase, what is the use of data if it is not being used? What USAID's experience with the development of the TB recovery plans has shown is that acting and responding is critical, even if the data might be still considered preliminary. In the last year, USAID also developed a comprehensive performance-based monitoring and evaluation framework, which standardized our TB measurements across USAID-supported countries. And it's also publicly available in English and Russian for the rest of the countries. USAID would continue to provide strong support to countries in improving their monitoring and evaluation systems and disease surveillance systems. The Global TB report makes a sobering reading, as it was already presented by you, Dr. Kasaeva. However, in this day and age, when science and objective evidence are under assault on so many fronts, it is also a reminder in the power of data to guide our programmatic and investment responses. We know that data can never be perfect, but that should not give us an excuse not to act on it and keep relentless efforts to improve its quality and use. And again, I would like to congratulate again your team and about the global TB report. The new format that Catherine presented is also very, very interesting, and I think it is more user friendly. It's great to see that these data now also available as applications that can be downloaded on our mobile devices, and really we have access to all of those data at our fingertips. And I also know the tremendous effort that went into developing the global TB report, and I would like to acknowledge all the hard work and efforts of WHO in bringing this report to the global TB community and making it available to all of us. The question now, of course, is for us to put to use these data and really utilize the data for our decision making and investment purposes. Thank you very much, and congratulations again on a job well done. Thank you very much.
So thank you very much, Sevim. Indeed, I can't agree more that data is essential for the actions, for the right programmatic decisions, and also for the investments. So with this, I would like to give floor to our colleague Elliot Wandala, Head of Tuberculosis Technical Advice and Partnership Department at the Global Fund. Global Fund is the top international donor financing TB efforts globally, especially in low and middle income countries. Please, Elliot, share your perspectives and on the TB response, what should be done urgently and how we can support this response.
Thank you, Teresa, and thank you, WHO colleagues, and good morning, good afternoon, good evening, colleagues. Also, I would like to join our colleagues from USA to congratulate WHO for this report, and also to congratulate WHO for showing the way to move more digital in web-centric manner in this context. I think in this context, we need to change, we need to move in that way, and WHO is showing the way on that aspect. We would like also to congratulate WHO for availability of data, timely data. We now get monthly reports, which is very critical for us at the Global Fund, and it has been very useful, especially in our C19 response. The funding requests were coming very quickly from the country, and the reports were very critical for us to make a decision on supporting countries, not only to respond to the COVID epidemic, but also to be able to put interventions to mitigate the impact of COVID on tuberculosis. The report today just confirmed what we have been observing in the countries since last year. We also released our results report last month, which echoed what has been highlighted by WHO. We have seen a decline of performance in most of the countries we are supporting, and this is not only for tuberculosis, but also for the other two diseases we are supporting. And this is the first time in the history of the Global Fund where we have reported less results. and is very concerning to us. I think we also saw in the report sobering result in terms of number who were treated, but also the number of missing people from tuberculosis. We have been working very closely with WHO, Stop TB, and other partners and countries to support countries to be able to find and treat people who are missing from treatment. And we have seen results before COVID. In fact, just in 2019, we were able to get additional 1 million people on treatment compared to the year before. And we are hoping that we'll be able to see more progress in this area. But COVID has wiped all those results. And today, as you have highlighted, Dr. Saiva, that there are more people who are missing from treatment compared to the year before. So this is a really sobering result, and we really need to do more in order to be able to get those people and put them on treatment. Through our COVID response mechanism, we have supported countries since 2020 to be able to respond to the COVID epidemic, to be able to mitigate the impact of COVID on TB, HIV, and malaria, but also to reinforce urgent community and health system. Up to last week, we have been able to approve more than 4 billion to support countries to be able to respond to the COVID and also to mitigate the impact of COVID on the 3 disease. In terms of TB, we have been able to approve more than 100 million through the C19 mechanism for more than 100 countries. And we think this will really help countries to be able to scale up their programs and to be able to mitigate the impact of COVID on tuberculosis. And this comes on top of one of our biggest grants, which we made available to the country. We have 24% more funding in this funding cycle compared to the previous cycle. So the hope is that countries would have been able to scale up their programs, and we saw the funding requests which we came in this round were very much ambitious compared to the funding request before. But we have a task now to help countries to be able to implement their programs because we know we have only 2 years to be able to implement their programs, 2022 and 2023. And it's a daunting task for everyone, for the countries. And we ask and call upon all partners and countries to work together to be able to utilize that money and be able to close the gap which we have seen created by COVID. I think one of the early sign and impact we saw during the early part of the epidemic is shifting of the resources from tuberculosis and of course other programs to COVID. And we are seeing that continue now because the resources are being shifted to the vaccination. And we need to work very closely with the country to ensure that countries have enough resources, human resource, to be able to mitigate the impact of COVID, but also to be able to scale up their programs. And as from the Global Fund, we are looking at the issue of human resource very closely. We know this has been a difficult area when it comes to the normal grant, but we are looking at it to be able to support countries to have innovative way of deploying enough resources, enough human resource to be able to support the programs. And we have seen a number of countries coming and requesting that urgent support. And we are looking at it to be able to see how we can support countries to be able to have enough human resource as well as other resources in order to be able to scale up their programs. We note with concern the decline of domestic funding for tuberculosis. This will have impact not only on the TB program, but we think across the health sector. And we ask partners to work with the countries to help them to advocate for more resources, not only to health, but for TB, and the country not to cut back on their domestic funding on the tuberculosis, because majority of the funding for tuberculosis comes from the domestic funding. Once again, I would like to congratulate WHO on this step and also to make this report more accessible and innovative way of doing things. And we think countries will take a lead from WHO to move more digitally. And we look forward to work with WHO and other partners to help countries to be able to scale up their programs to meet their targets, to meet the UNHLM target, but also to meet NTB target. Thank you.
Thank you very much, Elliot, for our strong collaboration, and also to the other colleagues from TB Situation Room working hand in hand on daily basis. So indeed, it's important and urgent to address all these critical gaps, both from the domestic and international funding sources. So that's why I would like to know to let know to the audience that WHO submitted official position paper on and request to the Global Fund Board to urgently increase funding for TB. And what is important, it's not a position of just global tuberculosis program, it's WHO position, and unanimous. We hope that there will be a response from the Global Fund Board, and of course domestic funding is critical and should be increased as well. So with this, I would like to move to our next round of speakers. As you know, in June, WHO released updated global list of high TB burden countries. We have 3 categories: high TB, TB HIV, and MDR TB. And 3 countries out of the main list, high TB burden country list, they left this year. They are Russian Federation, Cambodia, and Zimbabwe. And 3 other countries joined high TB burden country list: Gabon, Uganda, and Mongolia. So what does it mean for the countries leaving and for the countries entering? It's clear to all of us and to the countries that it doesn't mean that the focus should be left. It means that especially in the COVID situation, the focus should be strengthened. We are still far to our targets to NTB by 2030. So that's why I would like to give floor to the country representatives who are leaving, who just left the list, what they're intending to do, and those who are joining to share their ideas and plans. And now with this, I would like to invite Dr. Irina Vasilieva, Director of the National Medical Research Center for Physiopulmonology and Infectious Diseases and the Chief TB Specialist of the Ministry of Health of Russian Federation. Irina?
Good morning, dear colleagues, dear friends, dear Teresa. Thank you very much for giving me the floor. First of all, let me thank the entire team of WHO Global TB Program and its leader, Teresa Kasaeva, for releasing yet another WHO Global TB report, which is comprehensive and critical, not only for understanding and projecting the TB situation, but also for planning TB response. As you know, Russia has shown great progress in the fight against TB in recent years, and is finally excluded from the WHO list of countries with high TB burden. As the chief TB expert of the Russian Ministry of Health, I would like to note that it was possible due to the integrated intersectoral approach to TB control and a major political support of our action provided by the government. Over the past 20 years, Russia has implemented and continues to implement the national TB programs with stable financing, including direct supply. I would like to note particular importance of TB prevention and TB early detection programs. In our country, universal screening for TB among the entire population is being carried. For management of TB patients, Russia has a network of specialized healthcare facilities that implemented an interdisciplinary approach to treatment. Also, strict monitoring of treatment, promotion of adherence to treatment, and follow-up of treatment completion. I would like also to emphasize that all anti-TB measures, screening, diagnosis, treatment, and so on in Russia are completely free of charge. In addition, we have a development a system of social support available to all patients. Patients are guaranteed to keep their jobs, receive an allowance for the period of treatment, and are provided with housing. All these measures, along with systematic approach, have led to a significant reduction of incidence and mortalities in TB. At the same time, we realize that there are two very important and relevant challenges in Russia: MDR-TB and TB-HIV co-infection. We understand that these problems are of particular importance, and their solution requires a search for new effective approaches and technologies, development of new tools, and their rapid introduction into practice. Of course, the ongoing epidemic of COVID-19 requires adjustment of our life and work, complicating our tasks. At the same time, Russia has a strong scientific and organizational capacity available at the national research centers. The National TB Research Center, which I have the honor to head, and other research institutes, and there's also a network of WHO collaborating centers. All of this, with strong political support, makes it possible to strengthen our TB control efforts and hope of their success. Thank you very much, and congratulations for new WHO Global TB report. Thank you.
Thank you very much to you, Irina, and your colleagues for your hard, dedicated work, and to the Ministry of Health for the support. So it's great to see your achievements. So we hope that even in the COVID situation, we will manage to sustain. And I would like to remind to the audience that we've created also new category for the countries leaving list. They are now in the watch list. It means that we will be looking at them. We will not leave for the focus here, even at the global level. And we hope that the further progress will be provided. So I would like now to invite Dr. Charles Sandy, National TB Program Manager from Zimbabwe, that is also moving out of the list, to share your experience and your plans.
Thank you, Teresa, and good afternoon, good morning, good evening, all of you. It's a great honor to be allowed to have a few minutes to say one or two words about Zimbabwe. We are really happy as a country to be able to migrate from the list of high burden countries for TB, mainly because this is a reflection of the changes that we see in our incidents. We were happy very much before COVID started to show that the incidence declines may actually not be for long, and we have to be very, very cautious as we try to end TB. As a country, in response to the COVID mitigation, as part of the COVID mitigation, what we think is going to pull us out of the woods of a drop in treatment coverage is actually to take the services to the people. Most of our people do face challenges when it comes to accessing our health services. This is despite the fact that we have made tremendous improvement in having fixed services available when you look at the coverage of our GeneXpert machines. So our new strategy is actually to improve and expand on the coverage of X-ray, digital X-rays where we want to offer these services and screen more people. More so, I think what we have seen also from TB prevalence surveys is that there is a significant burden of subclinical TB. We haven't had a big conversation on what to do with subclinical TB. This contributes to the incidence of TB that we see, but we should have a plan to address it if we are to end our TB epidemic. I would like to thank WHO for the continued support to the country, as well as the Global Fund and USAID for the that is behind our success. And I wish to reiterate that our government remains committed to ending TB and continues to plow more in resources towards the national response. Thank you very much for your attention.
So thank you very much, Dr. Charsandy, and to your team. Really, it's extremely difficult, and appreciate all your efforts to sustain and provide continuation to the services. So I would like now to turn to Dr. Huat Chan Yuda, Director of SINAT, the Cambodian National TB Program, to share your thoughts and plans.
Thank you, Dr. Teresa Kasava, Director for the WHO Global TB Program. Yeah, really great and honor to allow me to say something about the special day. It is a good opportunity to participate in the Global TB Symposium today to make the launch of the 2021 Global TB report. As you know, Kingdom of the Cambodia, despite having remarkable progress and has already transitioning out of the list of the 30 high TB burden country, the country remains on the global TB watch list, which still warrant attention and priority. As we know, COVID-19 pandemic has reversed the gain of the TB achievement. Cambodia has made a great effort to reduce the COVID-19 impacts and sustain TB service. I am optimistic to take this opportunity to confirm that Cambodia is strongly committed to maintaining this momentum, double efforts to work to contribute reaching the TB milestone and TB target 2030. I thank you very much.
Dr. Yuda, and please continue the working and strengthening your focus on TB. We will be next to you and provide all necessary support. As we can see from the examples of 3 countries, and now they're in the watch list, that it can happen very fast. The negative changes in the epi situation and increase of the TB burden, but it took for some of you more than 2 decades to leave this list, even if there is a support from the political level, even if there is a sustainable financing. So it should be lesson learned by all of us. And now I would like to move to the countries that just entered the 30 high burden country list. And I would like to now turn to Mongolia, which is one of these countries. We look forward to hearing from Dr. Baigalma, Deputy Director in charge for the surveillance of communicable diseases, National Center for Communicable Disease, Mongolia. Dr. Baigalma.
Greetings to all distinguished country representatives, agencies, partners, and civil society organizations participating at the Global TB Symposium on this day. Mongolia is one of the 30 TB high burden countries in 2021, and one of the 7 countries in the WHO Western Pacific region with highest TB incidence. In recent years, TB accounts for 10% of all communicable diseases reported in Mongolia, and about 3,000 to 4,000 new cases are reported annually. TB is now #1 leading cause of death among communicable diseases. The government of Mongolia is committed to combating TB through participation and responsibilities of the government, donors, civil society, and private sectors. This initiative is guided by the United Nations Political Declaration on Ending TB and Ulaanbaatar Declaration on Ending TB. The TB control policy is reflected in Mongolia Sustainable Development Vision 2030 and priority areas for economic and social development and action plan of the government of Mongolia. In 2021, the funding for TB care and services is increased by 25%, which enables direct purchase of first and second line TB drugs from international pharmaceutical organizations. The latest digital technology and molecular biology diagnostic methods have been expanded in TB care, and now the detection and diagnostic capacity have improved at the national and local levels. We continue ensuring the sustainability of TB care and services and response actions during and beyond COVID-19 pandemic. Further contribution efforts are needed through multi-stakeholder cooperation on the implementation of set of measures such as providing real-time TB surveillance data and digitalization, and introducing new modalities of treatment and clinical care, and expanding research and studies, and increasing the accessibility of TB care to reach the unreached. We would like to thank the World Health Organization, the Global Fund, and other international and national partners, the National TB Program team members, doctors, and specialists for their great contribution to the fight against TB in Mongolia. Distinguished colleagues, I would like you all to join forces to build a TB-free society together. Thank you for your kind attention.
Thank you very much, Dr. Baygalma. I see also our colleagues from country office Mongolia and from regional offices also joined. We are working all together as one organization at all 3 levels, and we will continue providing all necessary support. So use this opportunity to share greetings to our colleagues. Thank you for collaboration. So this is end of our session. I hope that you found it useful. We see the growing interest, more than 400 participants, a lot of questions, and our leading experts, Dr. Matteo Zinio, Dr. Philippe Glaziou, and Dr. Denis Falzon, and others are actively responding to your questions. Please stay with us, stay active. And with this, I would like to give floor to my colleague Monica Diaz to inform you about our next steps.
Thank you, everyone, and greetings. So we'd like to take a small pause here. We'd like to see who's connected. As Teresa said, over 400 of you are connected, and we'd like to hear from you. Where are you from? And to see you. So I'm waiting for my colleague E to share the Slido. E, if you could share your screen. Okay. So what we'd like you to do very quickly is to use your phone and scan this. As you can see, there is, use your camera. You can scan very quickly here and tell us where you're from. Please list your name and yeah, just scan and tell us where you're from so we can see and hear from you. So it's good to see we have Thailand here. Please just scan the QR code and you can list name and country. So for instance, I'm putting down Monica, Switzerland for myself. Okay, we're seeing that there are a lot of people from France, Brazil, Japan, and a lot of colleagues. Yeah, thank you for showing. Yeah, thank you for showing us where you're from. It's a very exciting group here. Yeah, as you can see on the screen, we're a very big group, and I'd now like to take the opportunity. So we will save this, and thank you for joining the Global TB Symposium. We very much appreciate your support. We'd now like to move to the next part. I'd like you to prepare. We'd like you to prepare for the interactive open forum. And for this, if we could go to the next poll, E. Yeah, we have on Slido again, if you scan, we would like to hear from you. If you could tell us, what do you think is one quick solution that you see as a priority to rapidly ramp up the TB response to reach 2022 targets? Now, we just have 1 year to go, as Dr. Kasaeva has mentioned, and you've heard about the global report. Many of you have expressed concerns in the Q&A, and you will now hear on guidelines, research, innovations, and you will hear on multi-sectoral accountability. After that, we will have a session to basically collate all of your feedback. So this poll will remain open starting now. And we'd like to ask you, as you listen to the presentations, to start putting in what you think are your priorities. And at the end of this, we will go for a vote so that we can hear from you and consolidate your feedback. So back to you, Teresa.
Yes, thank you. Thank you very much, Monica. Please stay with us, be active. For us, it's very important to hear your feedback, your thoughts, so it can help us to move forward. And before we will move to the next session, I would like once again to thank all colleagues from countries, our colleagues from all three levels of organization, and our team in GTB working on the global TB report. Despite of all the challenges, we've managed in time and to do it more user-friendly and web-centric. We've received information from 197 countries, and more than 100 countries now are reporting on monthly and quarterly basis. It became happen due to our all joint collaborative efforts. Thank you. Now I'm pleased to go into the another very important part of the symposium. We would like to share with you key updates on the guidelines, our call to action with our Director General involvement, call to scale up TB preventive treatment, which severely lags behind, and our work on TB research and innovation. Following this, we'll look forward to hearing from partners on adaptation and implementation of guidelines with the Stop TB Partnership, and from UNITAID on intensifying TB research and innovation. And I will give a floor first to Matteo Zignol, our unit head from the Global TB Program, who will share the latest updates on WHO guidelines to end TB. Matteo, please.
Thank you very much, Teresa. I hope you can see my screen. Good morning, good afternoon, good evening, everyone. In the next 10 minutes, I'm going to give a very brief update on guidelines development here at WHO. First of all, to say that from this year, all our guidance throughout the spectrum of TB prevention, diagnosis, treatment, and care is available in one website. It's a platform which collects all our guidelines, implementation guide, and training catalogs. It's called the Knowledge Sharing Platform, and it's also available on an app. So you can have access to all our latest guidance through this platform. As I just mentioned, the platform includes the guidelines, the most recent one, the handbooks, implementation documents, training material, which is going to be populated in this month. You have a function to search for new recommendations, and also a function which is called recommendation map, which I'll explain in a moment. All the recommendations have been mapped, and you can look for them in multiple ways, either by theme, by thematic area, or by just searching in the free text sort of search function. The WHO recommendation policy guidance have been consolidated in 5 modules. The first is on prevention, second on screening, third on diagnosis, fourth on treatment, and fifth on vulnerable population and people-centered care. I go through very rapidly. The first module on prevention has been updated in 2020, so there was nothing really new this year. And I hope you have had a chance to look at it. It describes, the latest recommendation for TB preventive treatment. An important development of this year has been the dissemination of new guidance on systematic screening and also the operational handbook. This happened on occasional World TB Day earlier this year. And there are plenty new recommendations in this new module, both on the populations to be screened, but also on the tools that can be used for screening, which include molecular WHO recommended rapid diagnostics tests and also CheckSS-Array. We also have, for the first time, recommended the use of CAD, computer-aided detection, for the automated interpretation of CheckSS-Array. So I really invite you to review these guidelines. They are very, very interesting developments. On diagnosis, we have issued a new consolidated guidance in July. We are now providing a recommendation for classes of technologies. We have a recommendation for 3 new classes: the moderate complexity automated nets, the low complexity automated nets, and the high complexity reverse hybridization based nets. In the first group, it's a set of 4 technologies for the detection or resistance of TB and revamping INH resistance. In the second group, it's a new sort of XTR cartridges for the detection of quinolones and second-line agents and INH resistance. And the third class, we have a new technology for the detection of DZA resistance. We also issued a series of documents. I don't have time to go into details, but one important document is a mutation catalog, which for the first time lists mutations conferring resistance to MTB and their association with the phenotypic resistance. Now, when it comes to treatment, as you know, we did consolidate the guidelines on treatment of drug resistance last year. Last year. And we are now working on an update, which will be developed in the first months of next year. The same for drug susceptible TB. Actually, the update is under development. It may even come out before the end of this year. And it will be, for the first time, a consolidated guidelines on the treatment of drug susceptible TB. What's going to happen when it comes to treatment? Well, we have 2 shorter regimens for the treatment of drug susceptible TB. One is a 4-month quinolone-based regimen based on the results of Study 31, led by the US CDC and US NIH, and the 4-month regimen for children, which is based on the results of the STREAM trial. We have for drug-resistant TB, new updates coming up. One is the results of TB Practical, a randomized clinical trial looking into the effectiveness of BPAL-M for the treatment of MDR-TB, as well as new evidence on shorter regimens. And so all these evidence, including new updates on BPAL, will be reviewed in early 2022. We have also a series of additional normative documents, including revised XDR definitions, revised outcome definitions, and also will be soon issuing the results of a systematic review on the dosing of first-line regimens, first-line medicines for the treatment of TB in children and adults. For next year, we have the plan to update the target regimen profiles for the treatment of tuberculosis. You may have heard that there is been lots of work to update the guidance on the management of TB in children and adolescents. The GDG meeting was held in May, June. The guidance is going through internal review and will probably be available in early next year, together with an operational handbook to support implementation. As I mentioned, the guidance is nearly final. We had two important consultations between September and October to finalize the discussions. One is on dosing of bedaquiline and elamanid, and another one on the classification of intrathoracic TB in children. Of course, these guidelines will be made available through the WHO knowledge sharing platform. And last but not the least, there is important work going on the areas of human rights, social protection, and disability. We are releasing two operational handbooks, one on social protection and another one on ethics and human rights. And we have a consultation on social protection planned for December this year. So this is in a nutshell. I'd like to acknowledge a very large group of colleagues who have been working on these guidelines and implementation guide that you can see on the slide. And please do go to the TB knowledge sharing platform, download the app, and review our documents. Thank you very much.
Thank you very much, Matteo, really for your hard and dedicated work. And colleagues, you see that we are trying to do our best here to address all your needs and making uptake of the guidelines faster, easier, and more user-friendly. Or we're trying to consolidate all our products. All the guidelines are accompanied and released in the same time with the operational handbook. Now we are, this year we will present next month's training courses for the drug-resistant TB prevention and TB diagnosis. And now all the products are also available through the digital platforms. So we'll be looking forward to your further recommendations how to improve uptake, because in the current situation, especially if uptake will be provided, the treatment itself and treatment outcomes could be much better. Let's do our best all together. Now I would like to give floor to our next speaker, my colleague Avinash Kanchar, who will share with you information on implementing the call to action 2 on overcoming barriers in accelerating scale-up of TB prevention. Please, Avinash, floor is yours.
Thank you, Teresa. Hello, everyone. Let me start by reminding ourselves about the commitments from the member states at the UN high-level meeting in 2018. where the member states committed to support scale-up of access to testing for TB infection and providing TPT to 30 million individuals by 2022. And the progress towards these very ambitious targets had been quite slow to start with, and then in 2020 the pandemic hit and reversed some of the gains that we were starting to see in TPT coverage in countries. Around the same time, WHO also released the consolidated guidelines that Matteo just mentioned. And also WHO, along with several partners, came together to urge member states to enhance focus and increase coverage of TPT among contacts of TB patients, which was seen as the major gap in terms of coverage. Further, as a follow-up, last year, this year in June, we convened a high-level meeting, which was attended by ministers of health from 7 high TB burden countries, and more than 17 global partners joined hands, and the heads of agencies signed off to the call to action 2.0. This call had 3 major asks to increase coverage and achieve the target of 30 million on TPT by 2022. And the first and foremost among them has been need to strengthen finances and budgetary increase to the tune of about 1/3 of what is totally available at present, the 6.5 billion. And second is to expand the outreach and to reach households of all TB patients notified and provide on an average 3 individuals in contact with TB preventive treatment. At the same time, we will need to find and notify more TB patients through active case finding efforts among contacts, as well as informal settlements and high risk populations. So through these 3 major interventions, it is expected that the target of 30 million could be achieved. The call to action specifies 8 actions ranging from strengthening of the household contact investigation, enhancing access to diagnostic technologies, including digital chest X-ray and computer-aided detection software, reinforcing access to a shorter TPT regimen, learning from the massive scale up of TPT that has happened among people living with HIV, and creating a large scale communication and advocacy campaigns to increase the demand. So there are several of these actions that are included in the call. So I'll just take you through where we are. Some of these numbers you have already seen, but for TPT, we have seen some scale up over the last 5 years. In 2019, about 3.6 million individuals were put on TPT. But as with other data that we have seen, there has been about 20% drop in this coverage this year. So overall, just under 30% of the target for 22 is achieved, but for people living with HIV, the target of 6 million on TPT is already achieved. However, if we see at the details of the data, only 6 countries contribute to 75% of these TPT among people living with HIV. And there is a lot that needs to be done to enhance coverage and to achieve the NTB strategy target of 90% TPT coverage. Gaps remain amongst for TPT amongst contacts. Less than 30% of children who are contacts have received TPT, and under 2% of contacts who are more than 5 years have received TPT till date. So this remains the major gap in terms of coverage. And one of the important reasons is the coverage of household contact investigations. And from the map, you can see it's quite variable across countries. And moreover, we have seen about 30% decline in this coverage this year. And overall, just about 55% of contacts that are identified get evaluated. So this is an important reason for the massive backlog we see in terms of TPT coverage in contacts. So what has been happening since the call to action? The Global TB program has developed e-learning platform, and these learning modules would be very soon available, including for TB preventive treatment. There's this knowledge sharing platform which provides all the latest guidelines. We have developed an advanced version of a Prevent TB mobile application to help capture of data and case-based data and report using a DHIS2 based system. We plan a guideline development group to look at the latest evidence on tests for TB infection. So we'll have an expanded array of tests available soon. And we have been catalyzing availability of the shorter TPT regimen containing rifampicin through direct support in some of the countries. We have engaged extensively with all key partners who have been supportive of the prevention agenda. At the WHO regional office level as well, all our regional offices have convened regional webinars to disseminate the latest WHO guidelines. We have been engaging with at the regional level as well as at the country level to develop implementation plans. CRO, for example, has developed a regional action plan to scale up TB prevention. Similarly, situational assessments are happening across all regions, and we have done them for high burden countries as well as countries that are looking for TB elimination in the regions. At the country office level as well, the support has been expanded, and the pictures you see, the first one is the guideline for programmatic management of TPT that India has recently developed. Kazakhstan has also finalized its guidelines for TPT, integrating the latest screening elements as well. So there is this move around policy uptake in most of the countries. And we have been actively supporting uptake of shorter TPT through partnership with projects like Impact for TB. WHO is also supporting development of training material and contributing to the training of trainers. And we have been part of the planning and implementation as well. For example, for the TPT surge campaigns that many countries now plan. Following the call to action, and even before that, most of the key partners have been supporting the TPT agenda. The Global Fund, in its TB information note released in 2019, has urged countries to integrate TPT as a continuum of care for active TB case finding. The Global Fund also supports a strategic initiative of TPT amongst PL-HIV in 10 countries. USAID has convened an advisory group to support strengthening of the contact investigation, and the union has developed its own TB prevention training modules, which can be accessed as well. So, in general, there has been a momentum around supporting countries on the PMTPT agenda. The progress to date has been slow, particularly among the contacts of TB patients. But there is enhanced policy uptake and demand for TPT in general. I'll stop here and thank you.
Thank you very much, Avinash, for bringing to our attention this very important agenda. The role and the impact of TB prevention and TPT is well known, but it was for the years somehow undermined and then neglected, maybe partly due to the lack of funding, but it's indeed it's time to revamp this agenda, because it could be, in the absence of the new vaccines, the TB prevention and TPT could be game changers. So now I would like to move to another speaker and to cover a very important and also critically underfunded area of TB research and innovation. You know, the WHO adopted first global strategy for TB research and innovations, and we hope that it will boost and facilitate further efforts and investments in TB research. I would like to give floor to my colleague Nebert Gebrselassie to make overview of the current situation. Thank you.
Thank you, everybody. I hope you can hear me fine. Thank you, Teresa. Good morning, good afternoon. I will make efforts to quickly summarize at very high level the landscape of TB research and development over the past year, and some efforts that GTB has been making to help move this field forward. Are you able to hear me?
Yes, okay. Yes, please go
ahead.
Apologies.
Okay, so I'm going to start my presentation with this slide, but I won't go over this graph in detail at this stage. I'm sure everybody's familiar with this curve demonstrating that better implementation and evidence-based scale-up of existing strategies and introduction of better tools by 2025 is critical to accelerate the decline in TB incidence. And this tool set we envision to be introduced by 2025, which is just around the corner, include better diagnostics, including new point of care tests, safer and shorter treatment regimens, effective pre and post exposure vaccines. And it's also no secret that we are having challenge in aligning ourselves today with this curve, particularly also including the challenge we're having as a result of the pandemic, as discussed by colleagues earlier. So that being said, there is some progress in the development of new tools, and it's most obvious in the field of diagnostics, where the pipeline remains robust. The Global TB Report has more detailed information on new diagnostics, including those that are in the market and those under evaluation by WHO. And this is just showing a snapshot of those that are currently under clinical development. On treatment, in August, as of August this year, there were 25 drugs in trial for the treatment of TB infection, drug susceptible TB, as well as drug-resistant forms of TB. These drugs include 16 new chemical entities, and there are various combinations of regimens with both new and repurposed drugs, as well as host-directed therapies that are being tried at in late stage trials. And the majority of this regimens in trial are, of course, for the treatment of drug-resistant forms of TB. For TB infection, there are a couple of trials to improve care for eligible groups. These include trials for treating contacts of people with drug-resistant forms of TB, as well as for optimizing treatment of infection in children. So while all that I've shared so far for diagnostics and treatments are product focused, I want to acknowledge that there's a lot of research, operations research projects taking place to improve the implementation and scale up of this interventions, including those funded by Global Fund that we're not going over today. For vaccines, same as last year, we currently have 14 products and the pipeline, with a couple of candidates transitioning since last year from to efficacy trials to phase 3 trials, but the pipeline is still not robust. But hopefully within the next few years, we'll have some results from this late stage studies to understand better how these candidates are performing. The M72 vaccine, which showed a positive signal in prevention of disease trial a few years back, is currently undergoing safety and immunogenicity studies in people with HIV in South Africa. And we also understand that a phase 3 trial is being planned, hopefully to be implemented next year. So our message around the new TB vaccine remains the same. We need a greater number of new candidate vaccines to be tested and evaluated. We have some lessons from the COVID-19 pandemic that we hope can be leveraged. This includes the mRNA platforms, and of course, currently the pipeline focuses on narrow set of candidates TB antigens, and that needs to be diversified. So to stimulate this field of TB vaccines research, WHO is currently implementing full value assessment of new TB vaccines with support from the London School. So this basically is assessment or appraisal of, if you will, of broader health, social, and economic impact of new TB vaccines, with the vision of developing evidence for decision makers in late stage research, regulators, as well as those that are making decisions on vaccine introduction. So we are currently finalizing the findings, and we hope to publish a report on this next year. So in terms of how we're working with countries to promote research at WHO, we're using as Teresa mentioned, the global strategy for TB research and innovation as framework. As you know, this strategy was adopted by member states at the Assembly in 2020. And if I were to summarize the strategy in one slide, its vision or aim is really to drive discovery informed by needs on the ground. So both on aspects of what type of tools are needed, as well as on the attributes of the tools, such as affordability, accessibility, fit for purpose under low resource settings. It's basically better alignment of research with country needs and better collaboration and coordination in achieving that. So the strategy itself makes several recommendations under 4 objectives. I won't go over this in detail because of time, but of course one of them is increasing financial investments in TB research and innovation, which is critical. We have a severe funding gap of close to $1 billion a year, and this needs to be corrected for it to make progress. So to roll out the implementation of the strategy, an effort that we've made is to develop a desk review tool to help countries map what they have in place in terms of research, so they can understand better which recommendations from the strategy they need to prioritize. And this strategy and as well as this accompanying tool was developed at the height of the pandemic. And we have some examples of countries that managed to go through this exercise, and their experiences are documented in this checklist, in this tool. But we also were able to see that countries were naturally uptaking the recommendations and implementing them, mainly as a result of the challenge they faced due to the pandemic, particularly those aligned to improving approach to data sharing, particularly epidemiological data, sharing it at the subnational and national levels with partners, as well as with globally, including with WHO, and also improving access to TB services, embracing innovations to improve access to TB services and interventions. So earlier this year, we made a call for case studies to gather this effort by countries more systematically and share them with countries for mutual learning. We implemented an open call for case studies on programmatic innovation and during COVID-19, and we received about 23 case studies from all 6 WHO regions. The findings were published in May this year, and you can access them on our website. But basically, as I mentioned earlier, their countries are innovating across the cascade of care, including in sharing in surveillance and sharing of epidemiological data. More than half of the case studies describe successful implementation of digital interventions, including telemedicine and video-supported treatment to improve access to TB care. And there are other additional findings, which I hope you'll be able to access and learn from the report. So as the impact from the pandemic continues, we've been encouraged by countries and partners to continue collecting and sharing case studies. And we invite countries and partners to participate in this ongoing survey, which was launched in August this year. Last but not least, in terms of what's coming next, we are currently compiling, just to make a small announcement, research needs identified during TB policy guideline development. So these were research gaps identified by respective guideline development groups during evidence review. So these research gaps are currently in different guidelines, and all the guidelines, as Matteo has nicely summarized, are currently on the web on a knowledge sharing platform that we have. So we're basically making efforts to compile these, to pull them from the various guidelines and package them into an accessible and easy to use product. This is mainly done to increase their visibility and to build advocacy for this agenda. This research agenda that's coming from these guidelines is a bit unique because it's very policy focused. It focuses on increasing the certainty of the existing recommendations and also for stimulating the development or optimization of new recommendations that can improve patient health and welfare. So with that, I will close my presentation and thank you for your attention.
Thank you very much, Nebiat. And dear colleagues, I think that if you followed Nebiat's presentation, it should be clear that we here in WHO, we significantly shifted our approach from the passive reviewer and the dependency on the evidence coming to more proactive calls for the evidence, for the and strategy also showed this, and we expect also your contribution and further promotion of the research and innovation agenda. With this, I would like to stop and give floor to my colleague and friend, Dr. Lucica Ditiu, Executive Director of SOP-TB Partnership, with whom we are working on daily basis, and we have the same vision on the situation, on the perspectives, and what should be done. Please, Lucica, share with us your experience, your ideas, and what we can do better to make the diagnosis and treatment and the treatment outcomes, and in general the life of our TB patients better despite of the COVID situation. Please, floor is yours.
Yeah, so thank you very much, Teresa and the team. This was actually not only very much expected, this symposium, but amazing information that was shared. I'm very happy to be here with everyone. I'm very happy that there is a high attendance of 400 people here. What we discuss here is not great news, but I don't want to focus on not great news because I don't want us to give up, and I don't want us to be depressed, and I don't want us to feel like, you know, in spite of the fact that the epidemiology shows us a very you know, difficult situation, in spite of the fact that financial resources are not enough, in spite of the fact that we don't have attention of the big donors. Whatever we do, Global Fund is keeping us at a very low share of the portion, and we are struggling. We are struggling, but we should not give up. And Teresa said a very important point, and the colleagues before, and Matteo, and Avinash, and Nebiat, we and all the others before, obviously, WHO is moving at a very high speed in, you know, in upgrading, updating, changing, recommending the latest things in science for the programs. We in STOP-TB for several years now, we do an assessment called Step Up for TB. It was called Out of Step, together with partners from Médecins Sans Frontières as well as others, in looking at the uptake of the guidelines and recommendations in the countries. And what is happening now is that because the rhythm of updates and improvements that are coming, and thank you, Teresa and the team, for a very different approach than before, and the change and the speed. But what we all need to reflect collectively, and we need the NTPs to highlight for us, is the fact that we will need to provide help to the NTPs and to the countries to ensure that these new guidance, the new tools, new regimens are as quickly put into the national guidelines and being rolled out. We observe that this is not happening for TB. In the last Step Up for TB report, and as well in the Global TB report, we see that even the rapid molecular diagnosis that we have for 10 years, the gene expert. We have now another tool from the Indian manufacturers, similar with the other one. We, in spite of that, the scale up, the access and the uptake is very limited. I didn't look at the figures right now, but less than a third of people in 2019 had access to rapid molecular diagnosis. So what is that we need to change there? Is it that indeed to review the guidelines and the recommendations and the supply chain and procurement in the countries needs to keep up with this? Because then indeed we need to all come together and see what kind of help the NTPs will need to really keep up with this. Is it a reluctance because it's a new tool and let me see and sit and wait till more evidence is coming? Because whatever it is, we should try and overcome, because we saw that during COVID-19, it was possible to roll out new things like this, okay? And it was able that the countries got mobilized immediately. So we speak here of new tools that appear for diagnosis. We speak here a lot of digital technology, artificial intelligence, mobile units that can come closer to people, applications on the phones that look at the cough, that can identify TB and others. New regimens, there is a lot. I hope during the union, our colleagues from the TB Alliance and all the others will come with new type of regimens. I think UNITAID is funding some of this. This should be able to be rolled out and made accessible in the countries right away. And I know it's very easy to say here from Geneva to do that, but that's exactly the kind of conversation we should have. What is needed that we all do in such a way that we support? Because it's not enough that we in Stop TB, we produce a report and we tell, there are so many countries that didn't uptake these tools. COVID showed this possible. COVID showed what several colleagues said, that we can have live data. COVID showed that it's possible to scale up diagnosis. You see that you do PCR and you do this antigen test every single corner for COVID. TB is airborne, TB is growing. So can we think of, innovative ways of scaling up, and what is the barrier that doesn't allow us to do this? We in the Stop TB, this is my last point. I know we have Draurio speaking after me. I see here in the comment that the gene expert tests are too expensive. Yes, with the help of our colleagues, not only the civil society and the TAG and MSF driven campaigns, but indeed together with the main donors, actually there is and there will be a big push in decreasing the pricing. The decreasing is an egg and chicken thing. It comes with the pressure to ensure access and a big scale up. There is an hesitancy because we don't have all the money, so the scale up is not there. We need to really have a big movement in everyone shoulder to shoulder to really push forward the agenda and ensuring that everyone has access to the newest tools. You see, we need to stand up in hands, and because this is about rapid molecular diagnosis, is not the only thing we miss. We heard about TPT and so on, but speaking about that, and in terms of the new guidelines, I think none of us here on the call will accept for us or our families less than what is the latest recommended by WHO. I don't think, people will be happy if you go now and somebody will tell you, I'm going to diagnose your husband, your wife, your partner clinically or with smear. I think none of us will accept that. We'll say, okay, is this the latest thing available? And people will say, no, there is also Gene Expert or MolBio, but it's very expensive. So we should all say that we don't accept this not to be made available. And we should all construct our budgets and demands on thinking of everyone having access to it. And we will not get the money in the beginning, but we will need to continue the pressure of doing it. And this should be the shifted mindset. And we should not allow things that happened during COVID, in which just certain people had easier access than others to treatments, and the most vulnerable were left behind, or the ones from countries that were not that, high income or visible, received the latest, not only the vaccines now, but even the diagnosis, if you remember in the beginning. This is a long discussion, and I think, Teresa, maybe together we can put a session in which we discuss what we as a TB community need to do to take these new tools and run with them, because I think new regimens and new things will come up, and we cannot wait till 2029 to say we will need to scale up these things. I know it's not easy, but the fact that we have 400 people with us today means that people want, and we should not give up, and we should not be discouraged. And thank you, Teresa, Monica, and friends for putting this important webinar together. Thank you.
So thank you very much, Luchika. Fully agree with all your points. And when I'm receiving questions, is there a light at the end of the tunnel? We should show this light at the end of the tunnel to the people. And let's do our best for this. Thank you. My next speaker will be Draulio Barreira, representing Unitate, our partner closely involved in the promotion and acceleration and pushing of the research and innovation agenda for TB. Draulio, please, floor is yours.
Thank you, Teresa. Good morning, good afternoon, good evening, wherever you are. I would like to initially to congratulate WHO for this excellent quality global TB report, despite all the bad news that we were expecting, and also unprecedented production of recommendations, operational books, and guidelines. Really amazing. Congratulations, Teresa, and all the team. Talking about data, at the beginning of the COVID pandemic last year, WHO and Stop TB Partnership made a prediction feared by the TB community, which unfortunately has been confirmed. As Teresa and many colleagues showed, the new edition of the Global TB report brings the number of people with undiagnosed TB, it's increasing. Now up to 4.1 million people living with TB and without knowing about it. And worse, the number of deaths are increasing for the first time in a decade. So now we have again 1.5 million people dying per year. If we ask how this could happen with this millenary disease, the answer would not be surprising. The most popular and widespread tool to detecting TB, it's an invention that dates to the late 16th century, the microscope, as Lucica just mentioned. Of course, we have other tools, but not with the same coverage. We don't have a gene expert and a mobile everywhere, on the contrary. Thinking about vaccine, last July, we were celebrating 100 years of the only TB vaccine available. So let's move and think about COVID. Not even 2 years old disease. And how many new, affordable, rapid, even point of care tests do you have for COVID? Tens at least. And about vaccines, how many do we have? Maybe 10, and maybe more and more will come soon. Interestingly, we do not have yet any specific and definitive treatment for COVID, but it appears that early detection and mass vaccination are finally getting the pandemic under control. Why can't we do the same for TB? This is not so complicated question. Of course, we need the same political will, have investments and innovation to fight TB. Unitate, it's about innovation in health. We are working on innovative solutions for prevention, for diagnosis, for treatment, but innovation alone is not enough. As I said before, beyond microscope, we have good tools to detect TB, but it does not reach the people who need it most. We don't just need innovative solutions. We need innovative solutions that reach people in need. We have preventive therapy, and Avinash has shown just about this a few minutes ago, at least for decades. But the adoption of TPT has been very small. Now we are bringing, with support from partners such as Global Fund, Stop TB Partnership, civil society organizations, commitment of countries, a shorter, better, and more affordable treatment to prevent TB. The 3HP, 1HP, including fixed dose combinations and formulations for children as well. Diagnosis is another priority for us. We just approved last month 2 new projects to make diagnostic methods such as molecular testing, urine-LEN technology, digital tools and biomarkers more affordable, accessible, widespread, and easier to use. In recent years, Unitate has continuously increased the investment in TB. It's not enough yet, but we are increasing. We will continue to increase and fund a wide range of interventions to fight TB. UNITAID currently is funding projects on TB prevention, TB detection, better TB treatment and care for children and adults, better adherence to treatment technologies using digital technologies, and helping to improve MDR-TB treatment with better and shorter treatments, and also by sequencing the gene of TB. But now, with the lessons learned from COVID-19 pandemic, more than ever, we are going to focus on more impactful actions. These actions must be focused on diagnostic and prevention. I fully agree with Lucica. We must not give up on reaching the global targets. On the contrary, we learned a lot. With everything learned in the last 2 years with COVID pandemic, we must redouble our efforts and be sure that we can end TB. Thank you.
Thank you very much, Draulio. Yes, it was excellent, passionate statement, and your work in general is extremely important, and happy to collaborate and continue our collaboration. So now we are moving to the last, but another important, also very important panel on multi-sectoral action and accountability. We are all repeating that we should learn lessons from this this pandemic, and we should learn lessons in the right way. And obviously, one of them is that we can combat either old or new threats and epidemics only through engagement of multiple different sector stakeholders with clear roles and responsibilities, and implementation of the accountability principles. And so that's why we're extremely excited and working with all of you on the implementation and adaptation of the multi-sectoral accountability framework, MAF-TB, and which were requested by the UN high-level meeting on TB to develop. It gives us opportunity and mechanism how to implement in practice these multi-sectoral measures. And we, again, referring to our report, we see the growing role of the socio-economic determinants on the TB epidemic. It's not only just about the disruption of the health services, and also it will give us opportunity to hold accountable all the actors and not only traditional ministries of health, but also other players like manufacturers. They should be also responsible and accountable for the development of the tools. It should not be considered as just only private business decisions, and for the price and for all many things like this. So that's why we think that multi-sectoral framework it's the right way to move forward if we are serious about addressing our current critical gaps. So I would like now to give floor to our panelists, who represent different sector, important stakeholders, and to listen from them about their experience and ideas how we should move forward that direction. So first, I would like to give floor to my colleague Farai Mafunga, Unit Head for the Health for the Vulnerable Population Communities and Comorbidities of the Global Tuberculosis Program. Farai, could you please share an overview of progress on the implementation of WHO MAF-TB and its perspectives, please?
Okay, thank you, Teresa. Yes, I will go through just briefly our experience with the implementation of MAF, but also highlighting some of the feedback that we have gotten from countries as far as their experience with the implementation of MAF is concerned. So just a brief background in terms of MAF, as I'm sure many of you have been involved in the discussions around MAF-TB. Essentially, we all understand that TB is a social disease, it's an economic disease, And it's also a disease affected by many factors that are outside the purview of TB programs. And in the context of the SDGs, good health and well-being, SDG number 3 is central to the achievement of all the other SDGs. And we do know that ending TB is part of SDG number 3. So acknowledging that TB is driven by social and economic determinants, the political declaration of the 2018 UN high-level meeting on TB includes a commitment by member states to pursue multi-sectoral action and accountability to end TB. And WHO was requested to develop a framework and ensure its implementation. So this multi-sectoral accountability framework for TB was released in May 2019, and WHO is providing coordination, guidance, and support to countries for its implementation. So just to briefly highlight some of the, the key components of MAF-TB, as I'll be referring to these in the coming slides, we do have the commitments, the actions, the monitoring and review, monitoring and reporting, as well as the review of MAF. So in terms of WHO support for implementation of MAF, so WHO has been guiding and supporting member states to implement MAF since it was launched, leading and promoting collaboration across different stakeholders at various levels to implement MAF-TB, as well as developing tools to enable the uptake and expansion and country adaptation of MAF. Furthermore, at country level, WHO has been supporting baseline assessments, and I will briefly touch on some of the findings from these assessments that we have received from countries. And this is an example of the MAF checklist. It's just a section of it, and I would like to appreciate a number of countries that have provided feedback on the checklist that they have completed. And again, WHO has supported in the context of the multi-sectoral accountability framework, as we know that this is one of the key recommendations of the Secretary General's progress report on the implementation of the UN high-level meeting declaration, which includes ensuring that high-level multi-sectoral collaboration and accountability under the leadership of heads of state and government, including regular reviews, is in place, especially in countries with high burden of TB. And we also need to acknowledge that one of the key challenges that we are facing is COVID-19, and this has been highlighted through the data that have been shared so far and that are included in the Global TB report. And addressing the consequences of COVID, particularly the socioeconomic impact and the accompanying risk factors, such as, risk factors for TB, such as undernutrition, will require further strengthening of multi-sectoral actions. So at global level, some of the actions that WHO has been involved in include building capacity, increasing awareness, and sharing best practices and experiences of multi-sectoral engagement and accountability. And we have engaged and collaborated with various UN agencies, as well as various other stakeholders, including civil society. And WHO has organized End TB webinars with partners to again try to strengthen the support of MAF-TB. A special web portal, the WHO MAF-TB portal, is also available for information exchange, and I will briefly share the screen that you could also capture to be able to register and participate on that forum to share experiences as we continue to try and expand adaptation of MAF-TB. And we've also collaborated with the SPARCS Health and Social Protection Action Research and Knowledge Sharing Network on social protection. As we know, again, that's one of the key elements of the End TB strategy. And it is particularly important now in the context of COVID-19. And now looking at specifically the feedback that we've gotten from countries, and again, I would like to acknowledge the countries that have responded. Out of 157 countries, and including almost all the high burden countries, they have published annual reports on progress towards national TB-related targets and commitments. And we also see that national mechanisms for high-level review, they are in place in most of the countries that have reported. And similarly, civil society and affected communities are actively engaged in the multi-sectoral accountability review process in the majority of countries, more than 87 countries, and about half the high TB burden countries. And baseline assessments that were conducted, and we got feedback from 45 countries that responded and conducted these assessments. Basically, all the 4 components of MAF-TB are in place in 17 of the countries that reported, which means that this is something that is ongoing. So some countries have some components, but not all components are available in more than half the countries. However, the majority of the countries have indeed translated the SDG and TB strategy and UNHLM targets into national policies, and about less than half of the countries have managed to formalize the national multi-sectoral coordination mechanism. In terms of surveillance systems, most of the countries do have strong TB surveillance systems and are reporting annually, and we have noted from the Global TB report the data that have come through from the countries. And in terms of high-level leadership, again, the majority of countries do not yet have high-level leadership engagement in the periodic review of the TB response. And about half of the countries do not yet have clearly defined lists of stakeholders or performance measures for accountable stakeholders, with no budget outside the Ministry of Health to support TB interventions in other sectors. And in terms of sectors that are specifically involved, I think in most countries it is civil society and affected communities. However, only 9 countries have performance measures and indicators to measure civil society engagement. So in terms of the MAF-TB Networks platform, so I'll just leave this here for a few seconds for those who may be able to scan the code and join the MAF-TB platform, where we can network and discuss and try to collectively move together towards the country adaptation and implementation of MAF-TB. So I think in a nutshell, as you have noticed, all this information is available in the Global TB report. And I would like to acknowledge the various countries, government leaders, Ministry of Health, national TB programs that have provided the data and information that is included in this report, the UN agencies, civil society task force members, and other civil society representatives, and WHO at country, regional, and HQ level for participating in these processes. Thank you so much, and back to you, Teresa.
Thank you very much, Farai, for sharing this. And colleagues, we all understand that it's not easy task to implement MAF and to provide meaningful engagement of different sectors. It needs mindset shift and change, but it will be only one way, way to move forward if we really aim to attract not only different sectors, but also investments. In the current situation, it will be also extremely important. So now I would like to turn to Yulia Chorna from WHO Civil Society Task Force. And Yulia, please share with us what civil society and community actions can help to build on strength and accountability. Yulia, please.
Thank you, Teresa. I'm now trying to put on my slides. Is it portrayed? Okay. Yeah. Yeah. Thank you very much for giving me a floor and inviting me to present on behalf of the civil society task force hosted by WHO. It's a great pleasure and honor, and I would like to say good day and good morning to all the participants. Sorry. Okay. I would like to start my presentation with discussing a little bit about about the fact that accountability may take many forms and functions. And for purpose of today's presentations, I would like to particularly focus on the social accountability and multi-sectoral collaboration as the background of mutual accountability. So here in this slide, you see the scheme. I will only briefly discuss it, but you could have it more on the source. So here there is a model of social accountability, and on the left part there is a branches of government who are accountable for citizens, who are right holders, and also accountability from civil society. So if we speak about social accountability from the point of view of government, it's a responsibility of power holders to take their actions, to take responsibility for their actions and to achieve the targets specified in political commitments. We can relate it, for example, to sustainable development goals, to NTB strategies, to commitments of various high-level political declarations, including UN high-level meeting on TB political declaration. And basically, this is about how these commitments are put into actions. And I think this will also link to what Drory and Luchika said earlier, that we now need to see how the commitments are put into policies and into the practice, and how, for example, it is rolled out. So how the WHO guidelines are rolled out, whether there is shorter and better treatment regimen and effective diagnostic available to all people, and whether there are space for multi-sectoral collaboration and meaningful engagement of civil society and affected community. Here we see that the government is accountable to rights holders who are the citizens. Yeah, and then the civil society in the scheme is represented as a non-governmental and community-based organizations who are also accounted for their beneficiaries, people they serve, and basically people they serve also represent a share of the citizens who are right holders. So civil society and communities provide services, but they are also delegated by their beneficiaries to advocate on their behalf. So this is why they have a right to ask and to participate in the governance and policy setting processes. And as such, accountability of civil society itself is measured through their compliance to their mission, rule of law, quality of standards of care, and ethical norms and financial transparency. When we speak about mutual efforts and about joint efforts to achieve the end goal of ending TB, we need to think about preventative function of accountability. And here it is about how civil society and government can work together to be jointly accountable for their beneficiaries, for citizens. And this goes to the concept of mutual collaboration and accountability. Basically, it's the same coin. Yeah, it's just like two flips of the same coin, that in order to be accountable, you also need to collaborate. You need to know what are the channels of your accountability, for what are the purposes of this collaboration, especially when it goes to inclusion of multi-sectoral stakeholders as in multi-sectoral accountability framework. On this slide, let's now look at the examples of civil society and community actions to build accountability within this broader concept of accountability and collaboration. And as I mentioned already, although we speak about civil society, actions of civil society are not possible to be effective if they're not backed up by governmental action to ensure enabling environment for public participation. So, for example, when we speak about accountable server delivery, what does it look like? It's any types of services, including community-based services, which should be driven by ethical and quality standards and include feedback mechanisms from the people we serve. So our beneficiaries need to be able to provide the feedback, whether they found the service satisfactory, whether they like it, how qualitative it is. And currently, we all know that a great deal of services on TB care and support for the most vulnerable and hard to reach populations are provided by non-governmental civil society, non-profit organizations within the support of donor funding. However, sustainability of such services are to be ensured by government, and it's then a governmental part of accountability. There should be regulations on the standards of care and procurement mechanism with sustainable national budgets, as well as capacity building programs on WHO guidance and evidence-based approaches, which should be also open and available for civil society and community providers. So this is an example how these both parts of accountability match together. The second example is about monitoring and reporting. Community-based monitoring of the accessibility of TB care and is an important dimension of accountability. However, it is within governmental action to ensure supportive environment for community-based monitoring, to ensure the success for communities to be able to do the monitoring at the base of facilities and beyond. And then also to support taking measures to address identified systematic barriers. Another example is reporting. Civil society and community stakeholders should ensure accountability towards people they serve and broader community on the progress achieved through their own annual reports. And there should be also data collection and reporting on broad social indicators to identify areas and most vulnerable groups which need support and need greater attention through community rights and gender assessment and stigma assessment. It's like a tool which this accountability could be performed and ensured. And the governmental action in this regard is to ensure open access to disease statistics and budget spending in the open sources and advancing disaggregation of data to account for social indicators of tuberculosis and producing comprehensive annual tuberculosis report, which is inclusive and which has also multi-sectoral perspective and account for input from civil society and community organizations. Also, accountability is ensured through collaboration and public participation, and civil society and communities should contribute to national working groups, which works on health strategies, on operational planning, on budget priority settings. But again, there should be seats secured for them to participate, and this should be secured by government in line with the values of public participation, including at the highest level. When we speak about MAF, it should be at the level of the high level review. And last example on actions to build multi-sectoral accountability might be illustrated through civil society advocacy to address social determinants and risk factors on tuberculosis and advance people-centered models of tuberculosis. This is something which Farai was also mentioning in his presentation. And for this course of action, again, there should be collaboration with the government and initiation of the government of revision and development of the legislation on tuberculosis, which would be ethical, include ethical provisions for TB care, and as well, it should not be only limited to legislation directly related to medical aspects of TB. It should be also legislation on social protection and welfare, which should take care of the broader social determinants and risk factors of tuberculosis. And here I will not stop because I already talked a lot about these tools, about MAF TB tools and its components. I just want to highlight that assessment also includes Annex 2, which is engagement of civil society and affected communities in MAF TB. And this Annex 2 was developed with participation of civil society task force and also now actively implemented in many countries throughout the world with the active lead of civil society and effective community. Now I would like to draw on the example of stages to launch MAV-TB, and which is adopted from the approach of WHO Regional Office for Europe for Eastern Europe and Central Asia pilot countries, where there was a pilot together with TB Europe Coalition to set and implement these baseline assessments. And TB affected communities and civil society should have instrumental role in all the stages. So the first one is that in consultation with NTP and the relevant country multi-sectoral coordination body mechanism to basically initiate the discussion about MAV-TB at the country level. Then it is important for civil society and communities to be part of the discussions and planning from the very beginning and throughout all the stages, because then it will be like real demonstration of a participatory approach and meaningful engagement. And then it is direct engagement in MAV-TB assessment and leading on assessing the role of TB civil society and community with the use of Annex 2. And further on, it should be led with formalization of the MAV-TB coordination and high-level review mechanisms and adequate representation of the civil society and affected community in both structures. And last but not least, that it should be advocacy in place, supported or led by civil society. And yeah, I'm wrapping up. And this kind of MAV-TB high-level review should be led by the head of state or head of government.
Very much. Thank you for your passion and excellent collaboration at all levels. And we can see on your example how civil society and affected could become real drivers of all this process. Please continue, and we're proud to work with you. Thank you. Now I would like to turn to Guy Stolworthy, Global Lead for Private Provider Engagement, TB-HIV, and the Bill and Melinda Gates Foundation. Guy, please share with us your ideas, your perspectives on the importance of private sector engagement and accountability, and how we can strengthen this collaboration. Please.
Thank you very much, Dr. Teresa. 3 years ago, WHO and partners launched a roadmap for public-private mix for TB. Outlining 10 actions needed to engage all healthcare providers on a scale commensurate with the MTB goals. One of the commitments we all made back then was to monitor progress and build accountability in this area. And this is a good time to reflect on how well we're doing against that commitment. Next slide, please. And you can go to the next slide. So let's see if we can be clear on what we mean by accountability in this area by posing 4 questions. Who is to be held to account, and for doing what, and by whom and how? And for the first question, we may think of 3 categories of actors: healthcare providers, programs at various levels, and the international TB community, by which I mean WHO and the funders and technical agencies. Any licensed healthcare provider has obligations to comply with treatment standards and reporting requirements. And for the rest of us, our obligation is to engage with the private healthcare sector on a scale that's commensurate with their importance in each locality. And we may think of this as consisting of 2 components: how much are we trying and how well are we doing? But accountability is an abstract concept unless someone is holding people to account for what they should be doing. And here we all have a role to play. It's particularly appropriate that I speak after Yulia, because civil society and TB advocates are obviously critical. And these are complex processes of political economy and ultimately of power relationships. But all of them depend on the critical element that is data. We know that TB programs are particularly rich in data, but data on private provider engagement remains embarrassingly weak. This is a reflection of low priority that's been given to this issue, even in the highest burden countries that have dominant private healthcare sectors. Next slide, please. So what data are we talking about here? In preparation for this meeting, I spent many hours studying global TB websites and those of national TB programs of the highest burden countries that have dominant private healthcare sectors. And first, allow me to congratulate all those involved in producing another rigorous and innovative global TB report. Since 2010, this report has included data on public-private mixed notifications from priority countries. But we're not yet in a position to consistently distinguish contributions of NGOs from those of the more numerous for-profit providers. There are excellent dashboards from the Stop TB Partnership and the USAID TB-VIH project that don't seem to include data on PPM. At country level, the Philippines, Indonesia, India, and others now have impressive online TB data dashboards with near real-time TB data. But only India has data on PPM, and that's limited to notifications. Many countries post online their annual TB reports and reports of joint monitoring missions, although these are not often up to date. And from these, we can find some more information. So it's indeed good that over the last 10 years, data on PPM notifications have become generally available, but it's almost impossible to find any publicly available data on the services that are provided to these privately notified patients, diagnosis, drugs, and social support, or on the quality of care that they receive, or the numbers of providers who are engaged, or on the allocation of resources to this effort. Some countries have better data than others, but all could do better. In some cases, joint monitoring missions have found, for example, that we have claimed credit for private TB case finding without providing any services to those patients or even knowing whether they took treatment or survived their illness. Patient advocates should be holding us to account for this. Now, there are important efforts underway to improve the availability of data, especially via the case-based digital information systems. But these efforts clearly need to be strengthened. Yet, even as we improve the availability of data to programs, we also have to ensure data transparency so that it's readily available to elected representatives in the media and civil society, even when it may be unflattering, if we want accountability. So in sum, I would say if we're serious about ending TB, we know we have to be serious about engaging the private healthcare sector in many countries. And if we're serious about that, then we have to have accountability at every level. We can't claim to believe in accountability unless we're serious about making rich data publicly available. And in this respect, for private sector engagement, we've still a long way to go. I'm pleased to say that we at the Gates Foundation will support a major effort by WHO in this area over the coming years. But it's an effort in which I hope we will all play critical roles. Thank you for your attention. Back to you.
Very much, Guy, for collaboration and very concrete and strong proposals. Yes, I agree with you. Sometimes in many cases, private care providers are like in gray area, and without understanding their role, the quality of care provided, we can't move forward. In many countries, they're playing really very important role. So that's why we're definitely looking forward to our further collaboration and hope next year report will respond to some of your questions you've put today. So now I would like to give a floor to our last but not least panelist, Madhusudan Kaple from WHO's 1+1 Youth Initiative on Ending TB. And he shows with his engagement clear example that TB is business for all, not only for the healthcare provided, not only for the affected communities, and young people can play very important role. Madhusudan, please share with us what is ongoing within the WHO 1+1 initiative and how youth engagement can keep us accountable to end TB.
Thank you so much, Dr. Teresa. It is really my privilege to be here. I will not take much time. I'll just focus on what we are currently doing and what we are aiming for coming days. Since the launch of global TB report, we can look at the numbers of young people affected by tuberculosis, and we also can look at the number of young people in total population, even more in high burden countries. we consider young people as important part of TB community, civil society, as well as health system, as a young medical professional and public health advocate in their community. So considering that fact, WHO launched a special program, a youth program, which is also known as WHO 1+1 Youth Initiative, to provide opportunity for young people to participate at various level TB activities, from global level policy making to community level youth engagement. So since the launch of youth initiative and youth declaration to end TB, we have seen some great example from different countries, from loose network activity, provincial level activity in Nepal, to national youth body from National TB program, Vietnam, to youth network in Indonesia, and from so many other countries. So till now, we are being able to make a network of youths from more than 90+ countries, and the number is growing every day. And here are some glimpses of activities that young people are doing in various countries. So I want to focus on how we are aiming to engage young people in future. So the first priority for us is youth training. We really understand that there is a need of capacity building for all young people who are looking for appropriate training course, appropriate opportunity, so that they can grow themselves before they try to contribute from their part in the community. So we are currently building youth training, and we are hoping that we'll be able to provide this training course as soon as possible before the end of this year. And second priority is the country support for youth leader recruitment and advocacy activities. We strongly believe that young people are not only accountable, but also they can hold countries, donors, and partners accountable to the civil society and the community people. So this is really important point to consider. And the third priority is youth community engagement. So we are really looking forward to collaborate with national TB programs, our partners, and organizations to move forward with these priority action areas. And there are lots of opportunity for young people to join our official movement, to get information regarding our work, as well as the opportunity to learn technically from officially from our official channel in various means. So this is all from my part. Thank you so much, and we really look forward to work with partners for this agenda. Thank you.
So thank you very much, Madhusudan, and apologize for putting you in such a frames. You are doing a great job, and thank you for your inspiration and bringing young energy. So please stay with us, continue working with such a passion. Thank you. Now, I would like quickly to invite Monica Diaz to take us through the interactive open forum, what is happening, and before we will close.
Yes, so we're running out of time, but very quickly, just to thank all of you colleagues. We have over 45 responses received. We asked for inputs on listing one quick solution that you see as a priority to ramp up the TB response for to reach the targets. And we see that there are a range of feedback from improving availability of tests, to securing more funding, research, engaging with the private sector, engaging with youth, and investment in civil society engagement, addressing stigma, gender equitable access to care. So a whole range, and we're very appreciative of all of these inputs. We don't have time to go into a full poll, but the idea was that we would go through this and we would have you rank what you think are important for you. So if you are able to go on Slido, scan it. We will look for your inputs after we close. So we invite you to go online, to vote, to see which you think are key priorities. And we very much thank you for being so interactive and providing your inputs both in the Q&A as well as on Slido on this interactive forum. Thank you very much.
Thank you very much, Monica. And now I am pleased to invite Dr. Ren Mingwei, WHO Assistant Director General for the Universal Health Coverage, Communicable and Non-Communicable Diseases. He heads the division. The Global TB Program is housed under and champions NTB efforts with unwavering support. Dr. Ren, would appreciate your closing this important event.
Thank you, Teresa, and thank you to all my colleagues, partners, and friends, panelists, and all the friends who share your inputs in the Slido platform, which absolutely much valuable and inspiring us further on the way to our global target to NTB. Today's discussion and dialogue at these important symposiums to mark the launch of 2021 Global TB Report are important as we take stock of the situation and recommend to accelerating the TB response with just 1 year to go to reach 2022 UN TB targets. The COVID-19 pandemic has reversed progress. This doesn't mean we should step back, but this alarming message and information reflected clearly in the recently released Global TB Report must serve the global warming up call to the need for the investment and innovation to close the gaps in the diagnosis, treatment, and care for millions of people affected by this ancient but preventable and treatable disease. Linked to the data coming out of the report, I'm pleased to see the discussions today on translating the guidelines to the actions on the ground to save the millions of lives, of harnessing the research innovations and joining forces across all sectors, building greater multi-sectors action and accountability. The countries, the partners, the civil societies gathered here today are a testament to the continuing commitment to not let millions of lives and their families down. In the face of the COVID-19 pandemic and linked challenges, as many speakers said, we need to redouble our efforts to ensure all people with TB access to quality care in line with WHO drive towards achieving universal health coverage, particularly for the most poor and vulnerable populations worldwide. We must face hands-on the social drivers of this disease and work loudly across sectors, promoting accountability. Our work on ending TB will not only save the lives, but strengthen families, communities, and economies and countries. As you're all aware, investing in tuberculosis remains one of the best buys in the global health, with reduction in TB incidence, unlocking humans' potential and economy's growth. We as a collective have ethic obligations to continue to protect and ensure that men and women and children we are still missing in the hardest hit of the countries, cities, and communities have access to TB prevention and care services that allow them to survive and thrive. Together, we are stronger. Together, we will success in ending TB. The clock is ticking. Thank you again. Thank you to all my colleagues in WHO, from regional office, country office, of course, in headquarters, to make this symposium a success. With that, thank you again to Teresa.
Thank you very much. Thank you very much.
Bye-bye.
Bye, thank you.